بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, السلام عليكم ورحمة الله وبركاته. إخواني وأخواتي الكرام، أسعد الله مساءكم بكل خير وبركة. بحييكم أجمل الترحيب في هذا اللقاء العلمي المبارك إن شاء الله. And I would like to welcome everyone, for this scientific event, which is under the umbrella of the Saudi Society for Family and Community Medicine, sponsored by the GSK and organized by Fexus Company. And today, ladies and gentlemen, we are going to talk about a very important subject that touched the reality of our real concern in practicing our medicine and saving the population health, in fact, during certain circumstances. So today our presentation is going to be about the meningococcal meningitis serotype B in the Kingdom of Saudi Arabia, the risk and solutions. And of course, all of you know that meningococcal disease remains an important public health threat globally, with a special focus in the Kingdom of Saudi Arabia. Why? Because we have been privileged as a country, as a community in the Kingdom of Saudi Arabia, to host the largest global mass gathering during the Hajj and Umrah season. And that's why this kind of gathering will put our pilgrims in the risk of contracting the disease, many diseases, with a special focus on meningitis disease. The current Hajj and Umrah meningitis preventive measures do not, in fact, exert, the specific protections to save the health of our pilgrims during the Hajj, and especially with a special focus that we are encountering across the globe, a new serogroup for meningitis, which is the B and X. And that's why today, ladies and gentlemen, we are going to shed a light on these important serogroups. And for this, we have been privileged to have a very important topic that will be discussed. And we have been privileged to have also a unique speakers who are going to enrich our scientific event with a lot of ideas, informations, and expertise. So we have Dr. Sara Al-Muammar, and we have Dr. Salah Al-Lawaidi from Oman, and we have Dr. Sardar Öztürk, and they are going to shed lights on the whole subject, starting from meningitis disease, epidemiology, and risk groups, and the burden of the problem in the Kingdom of Saudi Arabia, as well as the preventions approach for special risk groups, and the vaccinations which will be defeating the meningitis, inshallah. So I'm very sure that we are going to have a very interesting session today. And I would like just to remind you that this scientific event has been accredited by the Saudi Commission for Health and Specialty for 2 hours, CMEs. And I would like to urge all of you to put your questions in the Q&A box, so we'll be able to answer the most important questions that is relevant to our talk today. So I'm very sure that this scientific sessions will be quite interesting for all of us. And I would like to start with introducing the first speaker, Dr. Sara Al-Muammar. All of us, we know her. She is a very prominent and eminent speaker in different specialties, because she's a family physician, and she's assistant professor and a consultant family medicine in King Abdulaziz University Hospital, academic coordinator. And she was also assistant professor, Department of Family Medicine and Community Medicine in the College of Medicine of Imam Abdurrahman bin Faisal University in Dammam. She has a large working experience and in many universities, hospitals, and even in Ministry of Health when she was serving Ministry of Health. And she has a good teaching experience, and she was engaged and still engaging in teaching the under and the post-graduation candidates. And she has a lot of professional community membership. One of it is the American Academy of Family Medicine, and she had the Saudi Society of Family and Community Medicine. She has a great number of publications and research, and she is also working for a charity and volunteering in a variety of fields. I'm sure Dr. Sarah will add to our scientific event a lot of values, and her speech will be about meningitis disease, epidemiology, and the risk group burden. So I will leave you with Dr. Sarah, and I'm very sure that this will be quite interesting. Thank you, Dr. Sarah, for accepting our invitations, and I will leave the floor for you. Thank you.
Thank you. Thank you, Dr. Ashraf, for the great introduction. Thank you very much. Bismillah ar-Rahman ar-Rahim. Today I would like to start our talk about meningococcal disease, specifically by the epidemiology of meningococcal disease. During this talk, we'll cover the definition, risk factors, transmission, and both national and international epidemiology. So before we start, I'd like to go back to the basics. What is the definition of meningitis? Meningitis is basically the inflammation of the meninges, which are the three thin layers or tissue that covers or protect the brain and the spinal cord. However, we usually say the word meningitis, meaning an infectious meningitis or infectious cause. However, there are two types of meningitis: infectious and non-infectious. Infectious is commonly caused by viruses and bacteria, and less commonly by fungal and parasitic infection. The non-infectious causes could be cancer, drugs, autoimmune diseases, and even head injuries. Now, what's the difference between meningitis and meningococcal disease? Usually in the hospital or in everyday exchange, when we say meningitis, we actually mean meningitis caused by meningococcal disease. However, the word meningitis means any inflammation of the meninges. And the one that we're covering today is meningococcal disease, which means that it's caused by Neisseria meningitidis, which is a type of bacteria that causes the inflammation of the meninges. There are 12 serogroups of Neisseria meningitidis. However, the ones that actually are invasive and cause sepsis are serogroup A, B, C, W, X, and Y. These are the most important serogroups that we're going to talk about, inshallah. So again, let's have a brief history about meningococcal disease. So meningococcal disease actually, or an epidemic, was first mentioned in the 1850s or 1805, 1800s, afwan. Several other epidemics in Europe and the United States were described shortly afterward. In Africa, the first outbreak was described in 1840. And it has been, and Africa has been having more epidemics even in the 20th century. The first evidence that linked bacterial infection to the cause of meningitis was written by a bacteriologist called Anton in 1887. Now, the meaning of this, or the reason why I always mention brief history of any infectious disease, is because usually most infectious diseases we've been able to eradicate most of them, like smallpox and to a degree poliovirus, etc. However, meningitis has been a problem for humanity since the 1800s and up till the 21st century so far. What is the impact of the meningococcal disease? Well, the problem here is that it usually strikes young, previously healthy individuals, and it can progress over a matter of hours to death. The mortality can be very high if the infection is not treated appropriately. And even if it was treated, there would be long-term sequelae for the infection. Almost 10 to 15 in 100 people will die, and up to, I'm sorry, I just need to, okay. Up to 1 in 5 survivor will have long-term disability such as loss of limb, deafness, CNS problem, and brain damage. The mortality and morbidity from meningococcal disease has changed very little since the 1950s. Principally due to the inability to effectively manage the endotoxin that would induce vascular collapse. So basically, it's the mortality and morbidity, despite antibiotic treatment, is still pretty high. In population-based study, including all ages, the overall mortality of meningococcal disease was found to be around 7%. And in other study, it was 10 to 15%, which is, again, for an infectious disease in the 21st century, it's considered very, very high. So who's at risk? Who should be worried about this problem? Well, the first risk is age. Most cases of meningococcal infection happens in young children. It also happens in adolescents from 16 to 23 years old, and an older adult over 85 years. And then we have group setting. Any place where people are gathered or they live together, there's a risk, like college students, specifically freshmen who live in dormitory, and the military recruits. There are some certain medical conditions that we should be aware of, like persistent complement components deficiency, people who receive complement inhibitors. Usually as family physician, these patients, before they receive their medication, they will be sent back to their family physician to receive meningococcal vaccine along with other vaccination, just to protect them because they are at higher risk. Patient with HIV infection, patient who have functional or anatomic asplenia like thalassemia, sickle cell disease, etc. Now, before we continue on the risk, I'd just like to talk briefly about the college students in particular. We as family physician, we always have to complete the health certificate that the university abroad requests. Most of that have multiple vaccination requirements, two-step PPD, etc. So they usually require the meningococcal vaccine. However, they do not say which type of meningococcal vaccine. The one that we usually offer in Saudi Arabia is called the quadrivalent vaccine, which covers serogroup A, C, W, and Y. Usually, most of our students, when they go abroad, they go to the States, they go to the UK, Europe, Canada. The serogroup B meningococcal infection is actually more predominant there. They're more likely to get it. And even though I said in the health certificate that he's protected or he's vaccinated, in reality, the vaccine that he received did not cover serogroup B. This is why it's very, very important for us to know when we sign the health certificate, where is this person going? Which vaccination is actually required, and it will cover the risk group there. Before the introduction of the quadrivalent vaccine, the serogroup C was actually more common in the US. However, in 2005, they introduced the quadrivalent vaccine and it became now serogroup B. And this shows you the importance of the vaccination, that it actually decreases the incidence of meningococcal disease. Going back to the risk, the other risk factor is traveling, of course, to any place or any endemic areas where there is meningitis, like the African sub-Saharan belt. Occupational hazard, if you are a microbiologist, for example, then you're going to have to work with the Neisseria meningitis. Intimate contact of cases, and this is very, very important because we have to identify them and we have to start chemoprophylaxis and possible vaccination for these patients who are family members, college roommates, nursery school classmate, intimate kissing with multiple partners. So how does the Neisseria meningitis transmit? People spread meningococcal bacteria to others by exchanging respiratory and throat secretion. Usually it requires close contact. People with meningococcal disease and those who carry the bacteria asymptomatically in the nasopharynx can spread the bacteria. In the epidemic that happened in Saudi Arabia in 2000 during the pilgrim of Hajj, basically most patients were actually asymptomatic and they were spreading the infection. So this is very important for us to know that even if a person is asymptomatic, he can still transmit or transfer the infection to someone else. Humans are actually the only host. The average incubation period is 4 days, but it can range between 2 to 10 days. Like we said before, it is really, really fast. Now I want to go to the epidemiology. So the Neisseria meningitis can cause both endemic and epidemic infection. Meningococcal disease occurs worldwide, with the highest incidence of disease found in the meningitis belt of sub-Saharan Africa. As you can see, the area right here that are highlighted in green, from the Senegal on the left and then all the way through to Ethiopia. This is called the meningitis belt. And the reason why this is called the meningitis belt is because these areas are hyper-endemic with meningitis. Every 10 to 12 years, you're going to have another epidemic of meningitis. So the attack rates there is 100,000 cases per 100,000 population. Other regions of the world experience lower overall rates of disease and occasional outbreaks. In the meningitis belt, serogroup A historically account for 9 in 10 meningococcal disease cases. So most of it is serogroup A. Recent epidemics have been primarily due to serogroup C and W. Again, it's very important for us to know the serogroup so that when we offer protection, we know exactly what we're offering. In Europe, America, and Australia, serogroup B, C, and Y together account for a large majority of cases. The majority of invasive infection in England and Wales was caused by serogroup B and C. In the US, the highest case fatality was caused by serogroup W and serogroup C. The predominant serogroup causing infection in the state were B, C, and Y, 1/3 for each one. In one study, they said that the proportion of cases caused by each group actually varies by age. So serogroup C, Y, and W happened more in individuals who are older than 11 years of age. Serogroup B happened in children who are from birth to 5 years old. The highest incidence of disease occurred among infants, 2 to 3 months of age. However, the highest mortality occurred in patients over the age 85 years. Meningococcal infection displays seasonal variation attack rates. It's more in February and March and lowest in September. There is slight higher predominance to male compared to female. All right, so this picture was published by the WHO in January 2020. It shows you the serogroups in each area and what is the most common. The one written in bold or in high caps, this is more dominant, or it's more predominant in that area. The best way actually is to go into the CDC website and just enter the country that that person is going for, and then you will have the predominant strain there or serogroup. All right, so to summarize, A and C, it is more common in Africa. It is most likely the cause of the epidemics there. Serogroup W was actually responsible for the outbreak that happened in Saudi Arabia in 2000 during the Hajj. It represents least common serogroup of meningococci. It is more likely to cause meningosemia or septicemia. It's also associated with men who have sex with other men. Serogroup B was relatively had low incident rate. However, it is higher in Australia, Europe, North America, and South America. And these are the areas that usually used to have the quadrivalent vaccine before. Sub-Saharan Africa almost had near absence of the disease. All right, so let's go about national, on a national level. What do we ask our people who come to Saudi Arabia to do? The Ministry of Health mandates that anyone who's coming for Hajj or Umrah, he has to be vaccinated for the meningococcal vaccine. However, if you notice here, the requirement is the quadrivalent vaccine. The quadrivalent covers A, C, Y, and W, and it does not cover the B strain. So they said if you have the polysaccharide type, then you have to have the vaccination every 3 years. If you have the conjugated type, you have to get the vaccination every 5 years. The patient or the person who's traveling has to have the vaccine 10 days prior to his arrival to Saudi Arabia. Already mentioned that. So there was a narrative review that was published in 2021 talking about the epidemiology of invasive meningococcal disease in the Kingdom of Saudi Arabia. They said that the annual Hajj pilgrim has been associated with outbreaks of meningococcal disease, mainly to serogroup A and W. The narrative review basically describes studies or surveillance that has been published from 2012 to 2019. The introduction of the quadrivalent vaccination has actually led to decline in invasive meningococcal disease since 2002, both in the local population and patient or people who are visiting for Hajj and Umrah. From 2002 to 2011, we have 184 cases of invasive meningococcal disease were reported. The main cause were serogroup W, A, and serogroup B. And like we said before, by vaccination, we were not protected from serogroup B. Between 2012 and 2019, cases were less. However, the serogroup data were limited. Sporadic disease due to serogroup B and W were reported. Appraisal of available surveillance data indicate that existing surveillance system could be strengthened. As disease due to meningitis serogroup B remains a potential risk, additional immunization strategies should be considered. Preventive measures that are implemented by the Ministry of Health in Saudi Arabia, mainly the vaccination, has actually helped to decline the cases. There were no other epidemics after the year 2000. However, there are multiple cases that were documented. All right, so talking on a global level or global public health response, the WHO has endorsed a surveillance strategy to predict epidemics early and initiate vaccination drive. So whenever there's a case report of meningitis, they would go to that city, they will start vaccination, they will start treating the contact so it will not develop into an epidemic. The CDC responded in Africa by leading an international consortium called the menafri.net. in collaboration with the WHO, African Ministry of Health, and other partners. They have a website. It offers a lot of information regarding the meningococcal vaccine. They also do surveillance and recommendation. This is the website if you want to visit. So the Saudi Ministry of Health response reduced invasive meningococcal disease was basically through the immunization with the meningococcal or the quadrivalent vaccine. National surveillance to monitor epidemiological trend is important to help identify benefit and unmet needs in current immunization strategies. So to summarize, the Ministry of Health has tried its best to protect us against the meningococcal disease. However, the children and the travelers who come from pilgrims, who should be protected because they are a risk group, like we mentioned before, both of them do not receive all the serogroups that are common, and they're coming more and more relevant to us. The mortality and morbidity from meningococcal disease is high and it's serious, and we should all take it serious and watch out for symptoms and signs. The majority of cases, like we said, happen in young children, infants, and elderly. The epidemics happen at mainly at the meningitis belt of sub-Saharan Africa. There is more than 12 serotypes. It's very important that we know which one is common so we can offer proper protection. National health surveillance system to detect recent and current serotypes, cases, and outbreaks is necessary to implement preventive measures like vaccination and travel regulations. Us as physicians, we should check the epidemiological trends in each area in order to offer people the preventive measures to protect the community. These are my resources. Thank you very much.
Thank you very much, Dr. Sarah, for this wonderful presentation, which was quite illustrative, to the point, and touched most of the item that was a good introduction to start our webinar. حقيقة دكتورة سارة نشكرك جزيل الشكر على حرصك للمشاركة بالرغم من الظرف الطارئ، ظرف وفاة المغفور له بإذن الله أخوك. فنقدم لك العزاء دكتورة سارة في وفاة أخوها. عظم الله أجركم وأحسن عزاءكم وغفر لفقيدكم. جزاك الله خير. شكرا دكتورة سارة. So, ladies and gentlemen, we would like on your behalf to thank Dr. Sarah for her contribution and for her commitment, in fact, to attend our webinar in spite of the devastating circumstances that she's going through. So may Allah bless her and grant her all success and wealth and health as well. So, ladies and gentlemen, without any further ado, we would like to move to the second speaker. We are privileged, in fact, to have Dr. Salah Al-Awaidi. He's from Oman, and this is for the first time we are getting our colleagues and our brothers from our Oman. So we are very privileged to have them. Dr. Salah, he's a manager of expanded programs on immunization, the EPI, and he's the head of the epidemiological surveillance section, Minister of Health in Oman. And Dr. Salah is a medical director holding a master in epidemiology with the current post of communicable disease surveillance and control advisor to the office of the Undersecretary of the Health Affairs and the Ministry of Health in Oman. He currently advises on eradication, eliminations, and control of communicable disease of public health importance, in addition to the expanded programs of immunizations, vaccine supply chains, and system and international health regulations. In fact, Dr. Salah has a very huge CV. I don't know from which parts I should pick up. Anyhow, so in addition to, he played a fundamental role in reducing the mortality and morbidity of vaccine preventable disease for pediatric, adolescent, and adult populations. In the international arena, Dr. Salah had presented a number of important global advisory group, namely the TAG on poliomyelitis eradication in Pakistan, Afghanistan since 2013, and he had enriched the community, the medical community, with a lot of publications, a lot of contributions. So, Dr. Salah, we are privileged to have you with us here today, and we would like to thank you for accepting our invitations. And we cannot wait much, to hear from you regarding the meningococcal meningitis prevention's approach for people in a special risk group. So thank you very much. I'm looking forward to hear from you. Thank you.
Thank you. Thank you very much, Dr. Ashraf, for the kind introduction. And Assalamu alaikum wa masa al khair. First of all, I'd like to begin by saying how appreciative I am to the webinar organizer, and particularly for the Jam'iyyah Saudiya Litab al-Usra and GSK for inviting me to this illustrious webinar. Thank you so much, Dr. Ashraf. Well, I'll start by saying thank you so much to Dr. Sarah as well for her excellent presentation and made my talk going much smoother, as many of her talks will be a bit put it down from my presentation, and hope it will be further elaborated. Well, as Dr. Ashraf said, my presentation will be around elimination of meningococcal meningitis in Saudi Arabia, and a focus a bit on prevention approaches for people in spatial risk. And as I'm going through my talk, I'll be starting a bit on a background on invasive meningococcal diseases. I'm afraid Dr. Sarah has beautifully went through it, but I'll be touch upon on those areas as well. And then going through a bit on the global initiative on meningitis elimination that has been adopted around 2019 globally. And the idea behind it is to see how the countries, and in particularly in Saudi Arabia, how could they use that initiative in going to introducing other vaccine other than what is already being introduced in Saudi Arabia. And then historical burden of IMD in Saudi Arabia that you have already heard. I'll be touching upon on that as well. A bit try to put it down in areas that need to be looked into, and then prevention approaches for the people at high risk, and finally the summary and conclusions. Well, as you have already heard from Dr. Sarah, the Neisseria meningitis is a disease that can affect any age group that you could see over here. And however, we know that the disease is very much affected the younger one and the elderly one, but even the adults also could affect. And this is a disease that can affect and could really strike quickly and kill within hours, without doubt. Therefore, this guy who's really, as you see his hand, try to say hi, be careful. If you're not really looking at this guy carefully, he may be cause a lot of harm and really cause a deadly among the human being. Well, another thing that over the years, Saudi Arabia has been a fundamental a country to contribute towards a global incidence of IMD, as you could see. So the Saudi Arabia has contributed in providing a lot of information around the meningococcal as a whole, IMD. And you could see that it has been estimated as at early ages, 2001, that during a Hajj, this disease could be as high as 25 per 100,000 population. But again, this pyramid also gives us a lot of insightful of how the disease behaves in a different individual. And it's very interesting to see how we are at our country, we fit in this pyramid over here. And we could see as we're going along how Saudi Arabia and other Gulf countries could really show a lot of information and could fit in this pyramid. Well, before going into detail, I would like to spend a few minutes going through a global initiative that has been adopted by every country and mainly adopted by our ministers, which is elimination of meningitis by 2030. And through that global initiative, there are a number of visionary goals that has been adopted. So globally is expected to eliminate meningitis, that specific meningitis by 2030. It means 7 years down the road, the meningitis, specific bacterial meningitis need to be eliminated. And I want you to remember these numbers, because this is the number that we rely on and the global rely on to say whether that particular country has achieved the elimination or not. So to reduce the cases of vaccine preventable disease by 50% compared to the baseline, which is 2015, and reduce the mortality by 70%. In addition to that, reduce disability and improve quality of life of these individuals due to any cause of meningitis. And there are 5 pillars that has been adopted globally, and that's going to help countries moving toward the goals. One of them is diagnosis and treatment, and then the other one is the disease surveillance, because the disease play a fundamental role in identify the cases and therefore to know where you're going and looking at the impact of whatever the intervention that has been adopted. Of course, prevention, and this is a fundamental part of the pillars, which is mainly introduction of the vaccine, and then advocacy and engagement, which is our meeting is one of the meeting that considered to be playing a role in advocacy and supporting, as well as support and care for the people who really had a meningitis, and we're going to discuss a bit around it. Well, when we are talking about the global roadmap, meningitis, elimination of meningitis, there are the goal set up to focus on 4 bacteria, mainly for bacterial meningitis, and these due to the Neisseria meningitis, Streptococcus pneumoniae, and Haemophilus influenza, and the Streptococcus alacti, which is GPS. So these are the 4 bacteria that need to be focused in the coming 7 years by all the countries over there. So let us go and look at where are we in general, and specifically where is Saudi Arabia with respect to meningitis. So this is a map that has been produced sometime 2020, show the global incidence of all the causes of meningitis. And you could see that the Gulf countries as a whole, they are range, the incidence per 100,000 range between 15 to less than 50. So, but this is all causes of meningitis. So we all need to push ourselves as much as possible towards the yellow color over here. So hopefully the strategy need to be looked into to reach the target as much as possible. Well, when you look at the Saudi Arabia based on this literature that has been published last year, we see beautifully both the Streptococcus and Haemophilus influenza, along with the meningococcal, has a tremendously reduced over the years and reached a very low rate of the meningitis due to these 3 bugs over there. So, and when you look at the GPS quickly, we see Saudi Arabia has very good published data that shows where are we with respect to GPS, and you could see this is one publication that has been published 2018, showed that 19% among Saudi women admitted in labor to the King Fahd has been shown to be colonized with the GPS. And the overall incidence based on the literature, this study that has been published 2019, the GPS is around 0.51 per 1,000 live birth, unfortunately no mortality rate. And the good thing about this, the current rate that has been shown in Saudi Arabia, very much in line with the global rate, which is 0.45 per 100,000 live births over there. But again, mortality needed to be collect information. So the GBS and other meningitis, Saudi Arabia in a very good shape, but we need to be very careful with the data, as you're going to see in a few minutes. So let's just go quickly on epidemiology of invasive meningococcal disease in Saudi Arabia. And you can see here, I like to show you here that Saudi Arabia, along with the other Gulf country, and in addition to my beloved country, Oman, Kuwait, Bahrain, Qatar, and UAE, you could see as over the years, the bacterial meningitis, IMD incidence has really declined. You could see over here, and compared to the baseline, you're really reaching the target. So it's really going down. And similarly, you see the trend of IMD incidence in Oman and Kuwait as well, and Bahrain and Qatar. But as you see in UAE for the last 2 years, the incidence is not very much in line with the global trend. Well, if you look at the IMD incidence rate per 100,000 population over the year in Saudi Arabia, you see beautifully. And you see in 1987, they used to have the rate of IMD as high as 12.83. And over the year until 2010, the rate reduced tremendously. And this is, as you clearly know, that this is due to the amazing strategy of introducing the quadrivalent over the years in a different strategy that have been taken that has really impacted a lot. And this is the same study that Dr. Sarah showed you earlier on. And here what you could see beautifully that the meningococcal has been reduced over the year, which is a dark green. And the age group still over the years, we are having less than 5 years. And interestingly, which is I want you to share with you, based on this publication, majority of the cases that has been recorded over the year, they were among the Saudi's national as well as residents, this is a very important piece of information, because this is give us a lot of information how we need to protect our people despite of all these mass gathering that is taking place in Saudi Arabia, but we need to protect our individual. The other interesting thing is to see the serotyping over the years. So between 1995 and 1999, serotype A was the predominant serotype. As time goes by, we had serotype W135. Of course, with the introduction of vaccine, I want you to focus something interesting over here is emerging of serotype type B. So this year, there were hardly 6 cases. Within 2000 to 2011, the serotype B jumped to 19. And unfortunately, I couldn't find any literature provide us information about the serotyping from 2011 onward, which is, I'm going to show you whatever I have it so far. So replacing of serotype based on what we see is that this is a phenomenon that has been known a lot. And this is what's happening in Saudi Arabia and other countries as well. As you're introducing the vaccines, the vaccine serotypes are going down, and other serotypes that hasn't been covered are really coming up. So serotype B is really coming up. And again, the age group mainly under 15 years old. To summarize the IMD in Saudi Arabia, I was able to collect a few information. So between 2012 2019, based on the national surveillance, where they had 48 IMD cases that corresponded to 0.1 100,000 population. 75% were among the national and 62% among less than 15, and 70% of serotype isolated were among meningococcal serotype B, compared to the previous one was 16. So again, this is to emphasize the serotype B is emerging. Unfortunately, the other 2 years, 2020, 2021, you had a very low rate of meningococcal meningitis as a whole, with the majority of the cases were under 15 years old. Unfortunately, I couldn't see any publication that is addressing the issue of serotype, which is, I believe this is quite important. But again, when we see the number, these are very small numbers. I think if we are really going towards the elimination, we need to be very careful with the small numbers and make sure the surveillance is catching all the cases around the countries. And this is quite important, because the elimination means you need to make sure the surveillance is efficient and capturing every cases, and this is quite important. Well, when you look at the schedule in Saudi Arabia compared to other Gulf countries, has 2 doses of quadrivalent, which is, I believe this is quite efficient and has played a fundamental role in reducing the diseases for those corresponding serotypes. This is another interesting cartoon that I'd like to share with you. I want you to focus on Streptococcus pneumoniae Haemophilus influenza. So the younger one, then it should play a fundamental role in transmitting the disease to the adults and others, and as you see for Haemophilus. When you look at the Neisseria meningitis, the adults, the teenagers are playing a fundamental role in spreading the disease to the younger one and the adult one, which is quite different from others. And has been shown, the study, that these individuals, the adolescents, are highest in terms of carriage rates, which reach up to 24%. So I'm saying so because this has a huge implication of this knowledge, particularly now. For example, we know that there's a football was going on in Qatar now, and all these younger ones who are really going over there, they mix up everything, and when they come back, not only they happy because of this football, they bring sometimes all these diseases that we supposed to be quite expected. Well, going back to the comorbidity, we know that there are a number of these comorbidity increasing the risk of invasive meningococcal diseases, namely tobacco smoke, as people who are suffering from asplenia, HIV, traveling to the individual to epidemic areas, and others. And the reason behind it, without going to be due to the immune functioning defect or impaired among the, particularly I'm talking about those who are suffering from comorbidity. This is a study that has been shown that increased risk of MD associated, particularly in adult, among the solid organ transplantation, those who are suffering from hemolytic anemia, and we know that all Gulf countries, and particularly Saudi Arabia, sickle cell are one of the diseases that really high prevalence of the disease. So this has been shown a very high odds ratio. So sickle cell are to be one of the high risk groups, and the liver disease, cancer, diabetics should be odds ratio a bit high as well. And we know that the Gulf countries consider to be the highest prevalence of diabetes globally. So these are the individuals who really may be having a high risk of AMD associated and other neurological diseases and immune. Unfortunately, as of now, with the exception of this a paper that I have seen from Saudi Arabia describing the epidemiology and characteristic of sickle cell admit in Saudi Arabia. I haven't seen any other publication, neither in the Gulf country or in Saudi Arabia. So in this publication that published in 2000, describing this picture, clinical manifestation, and so the highest prevalence rate was for these individual UTI, osteomyelitis, and meningitis, although they haven't described what sort of meningitis, but meningitis to be one of the problem that these individuals are suffering from. Well, so going back to the summary, as I'm going through it, although the Saudi Arabia and many other, even Gulf countries, they show a small numbers, but we need to make sure that we have effective national surveillance system guide us to the prevention and control, and even looking for impact of vaccines, and make sure that private sector very well covered. And in addition to that, looking at the sequelae, we know that meningitis are having a lot of sequelae, and the surveillance of sequelae need to be in place. This is part of the requirement. And this is a study that has been published sometime 2021 and describing the sequelae as a result of post-discharge complication of the meningitis cases. In Saudi Arabia, there's a 2 publication. And in fact, Kuwait and Qatar, you see a lot of we could see a lot of long-term sequelae, whereas Saudi Arabia with these 2 publications hardly could see. So there is a need of long-term follow-up of these individuals who are suffering from the disease to see what sort of sequelae and how could we help them in overcome some of these problems that encounter. So again, going back to the roadmap, because I believe this is quite important, because we are the small number. One of the problems that we're suffering is diagnosis, and we know that. So diagnoses need to be tuned, and providing as much as possible all the laboratory tool in order to identify the bacterial meningitis and other meningococcal diseases as soon as possible. Prevention is a fundamental for the prevention of that disease, and we know that a high vaccination coverage among the population is a fundamental. And in addition to that, introduce new vaccine like meningococcal type B, which is really needed, because if you wanted to reach the elimination and clean up as much as possible without introduction of this vaccine, you'll be handicapped because you cannot clean everything. And of course, there are other serotypes could come up, but at least you may reach 50% or beyond that. And prevention, particularly focus on prevention of MD among high-risk group. I know Saudi Arabia do provide this vaccine, but again, I couldn't find the coverage of quadrivalent vaccine among high-risk group, which is, I hope this is going to be taken seriously to share the coverage rate among high-risk group, because they're really needed. Otherwise, they're going to go into all these problems, and provide them as much as possible all these rehabilitation requirement that they need. Advocacy, I've already said, talking about, because this is one way of going, and presentation is type of advocacy. So if I may say a few words that need to be remembered by you, that by 2030, the goal are to eliminate epidemic of bacterial meningitis, and Saudi Arabia is in going towards that. But Again, there are a few things need to be tuned here and there in order to reach the target. And we know that Saudi Arabia is a significant progress has been made. And again, as Abu said, the IMD is in Saudi Arabia still a threat, not only because of the Hajj wal Umrah. Now, for me, is any mass gathering that is taking place, there is a threat. And our countries and all Gulf countries, there is tons of these festivals going on here and there, and people are moving around. And this is another threat that we underestimating, that these teenagers are going over there, they're mixed up together, they could bring up the disease to the younger one and elder one. Again, the dynamic and unpredictable epidemiology of IMD, and this there is a need to have serotypes, identify the serotype as much as possible, because this is the only way that could guide us and give us a strong ground by which we could say, yes, we are doing better in controlling, eliminate the disease. And it is required a very strong surveillance, both the government and the private sector. So far, unfortunately, we don't have any data in Saudi Arabia with respect to disease burden and MDD and serotype among high-risk group. Unfortunately, I've tried a lot and I've asked a lot of people, and this is something that you need to think seriously, how you're going to collect the data among this high-risk group to see whether they've received the vaccine, whatever the vaccine that they're supposed to be given, whether they have suffered from the meningococcal diseases, and it's quite important. And again, recent data show emergence of serotype B, as I've already showed you. So meningococcal type B need to be considered, and we know vaccine are the best public health buy. There's no doubt for that. And additional immunization consideration to be considered, and particularly among high-risk group, and particularly meningococcal type B. I think by this, I would like to thank you so much for your attention and looking forward to your amazing questions. Thank you so much.
Thank you so much, Dr. Salah, for this wonderful presentation where you shed a light on the prevention approach to special risk populations for meningitis. And you have illustrated the current situations in the Kingdom of Saudi Arabia. So thank you so much for your contribution. And ladies and gentlemen, I would like to remind you to put your questions in the Q&A box. We already received a couple of them. And please make sure that you have registered your registrations of the Saudi Commission for Health Specialty in order to have the CME hours allocated for this scientific event. And now, ladies and gentlemen, I would like to move to our next speaker, who is Dr. Serdar Öztürk. He has a PhD in public health, and he's a co-author in multiple publications on vaccine preventable disease and vaccine hesitancy as well. He joined GSK in 2011, and he's a full-time employee in GSK Medical Affairs. So he's going to shed a light on vaccines defeating meningitis. And as we were speaking, and Dr. Salahi was mentioning about the WHO vision in 2030 to eradicate the meningitis disease. And we will have the clarity where we stand and how this vaccine will defeat the meningitis, inshallah, by the year of 2030. So thank you, Dr. Serdar, for being with us. I'm looking forward to have your presentation ready.
First of all, Dr. Ashraf, thank you very much for this kind introduction. And I would like to thank both esteemed speakers, Dr. Salah Al-Abedi. We met with him many years back, but he's getting younger. I'm getting older. Great to see you, sir. And also, I would like to highlight the importance of Dr. Asara's presentation at the beginning, because she set the tone by highlighting rightfully and acknowledging the importance of this deadly disease. So if you allow me, I would like to share my screen. Could you please confirm whether my screen is visible?
Yes, we can see it.
Thank you very much. And also, it's my duty to acknowledge the importance of Saudi Society of Family and Community Medicine because I certainly believe this type of meeting serves the general need of the public and as well as our esteemed participants. So without further ado, in the following minutes, I would like to share the vaccines defeating meningitis. And first thing is, let me you beautifully introduce myself. I'm a full-time employee in GSK. I'm working in medical affairs, and I have some publications. I have lucky enough to be participate some publications, specifically focusing on vaccine preventable diseases and the vaccine hesitancy. And my passion is vaccines and as well as public health. And let me start by highlighting the importance of IMD. As we all know, majority of all IMD cases are caused by 5 serogroups. And 6 serogroups, they are causing this invasive meningococcal disease. We know that. And thanks to previous presenters, I would like to directly jump on why WHO has announced this important global roadmap. And maybe a little bit trivial information, the defeating meningitis by 2030, it's a global roadmap, has been approved by 73rd session of World Health Assembly in November 2020. So it's a very recent development. And as Dr. Salah highlighted gracefully and importantly, this roadmap sets off a comprehensive vision. And I would like to highlight in here the importance of prevention and epidemic control, which particularly vaccines are playing an important factor in here. And following this, I would like to highlight, okay, vaccines. What is the starting point of the vaccines? It's basically coming from the polysaccharide capsule, which is the key in determining virulence. And we know 12 serogroups have been identified so far, but the 6 of them, A, B, C, W, X, and Y, they've been identified according to their polysaccharide capsule. So it's very easily understandable that these vaccines are based on this polysaccharide capsule to develop and create a prevention effort against invasive meningococcal disease. And this is the historical overview of an IMD vaccine development. As you can see in here, as early as 1974, first monovalent meningococcal polysaccharide vaccine licensed in USA. And since then, you can see in 1992, first clinical trials of conjugate vaccines, because we knew that polysaccharide vaccines, although they are great for adults, but they're ineffective under the age of 2 or 3. And also, if you repeated the dose, there is no boostability, and it creates even reduction of the overall antibodies. So therefore, increasing numbers of pharmaceutical companies and researchers, they interested to how to combine polysaccharide capsules with the conjugation technique in order to find out multiple and more effective solutions, vaccines. So in 1999, MenC conjugate vaccine first introduced in UK, and following this in 2005, first MenACWY vaccine, a conjugated vaccine, first licensed in USA. And we know that in the meningitis belt, with the help of PATH and WHO, MenA conjugate vaccine licensed and have been heavily used since then, and is very effective. And in 2010, GSK, MenACWY conjugate vaccine first licensed. And very interestingly, in 2013, MenB multi-component vaccine first licensed in Europe. And maybe in another session, we can discuss what will be the future look like for the vaccines. And we know that including GSK and other companies, we are looking for combination of these available serogroups into pentavalent combination vaccines. So this is a very generic introduction for historical overview of IMD vaccine development. And for me, this is the most important slide of my presentation. Currently, there are more than 45 countries in the world. They recommended they include vaccination against serogroups A, B, C, W, or Y in their immunization schedules. And at least 30 clinical recommendations exist for MenACWY and 26 for MenB. And this definitely emphasizes the importance of vaccination. But please allow me to highlight that. Is it enough? I don't think so. Because imagine that we are talking about a gram-negative, a pathogen can cause disease only in humans, and we have available vaccines, and also additional vaccines are under being development. So we have a chance to eliminate this threat related to Neisseria meningitis. It's possible. So these numbers, with the help of WHO, with the help of medical societies like we are working right now together, it's possible. So, for example, this is an example coming from Chile. They started to use ACWY vaccination due to outbreak in order to control, and then they put in the national immunization program. And as you can see in here, although it's impacting due to serogroup W, but the MAM-B is still at the plateau and there is no impact. And similarly, we saw that in the MAN-C prevention, they have established in Brazil, and MAN-C, of course, they established this vaccination, but there's no impact on MAN-B and MAN-W. So we cannot talk about, in this case, MAN-ACWY vaccination can impact other than ACWY. So therefore, there's no cross-protection with ACWY to MAN-B. But that's not the case in MAN-B. Maybe we can discuss this later on during the Q&A session. And also in Australia, this is interesting. First, they introduced 4-component MAN-B, which is Bexsero, currently available, only available MAN-B vaccine in Saudi Arabia. And then they put MAN-ACWY at the 12 months. And this is the South Australia, a region, a state, a part of Australia. And then they combine with the Bexsero program, and they add a MAN-ACWY vaccination for adolescents. And as you can see, the number of invasive meningococcal disease cases is dropped from 27 to 36 to 5 in the year 2020. So it's possible to prevent. And so with the help of this, and for the sake of time, I just would like to jump on currently available GSK licensed meningococcal vaccines. And first, why we need broad coverage. Maybe I can only add this slide in addition to previous presenters. They beautifully captured what is the importance. And also, with the help of this slide, I would like to highlight one additional single factor. In this presentation, you can see the 4 countries, same countries with the different time zones. For example, on the left-hand side, you can see United States in the year 2010 versus 2016. So taking a snapshot or a picture in time, it doesn't reflect the exact need of the healthcare system, because if you can take 2010, we can only postulate that MAN-Y is the only serogroup dominating. But if you're looking for 6 years later in the similar research, you can see the increasing numbers of serogroup B. When we go to Brazil, we saw C and W is increasing. In Colombia, from 2008 to 2017, you can see serogroup C is increasing. But when we look for, even in the 3 years time frame, when we look for Czech Republic, you can see B and C increasing. So it's not easy for us that we are covering all serogroups with the help of single vaccination. Unfortunately, this is not possible. And with the help of this presentation, I would like to remind once more, we need a broad coverage, but with both ACWY and MAN-B vaccines, because we know that serogroup distribution is dynamic and making trends unpredictable. And of course, there's one additional aspect of this, especially Dr. Salah highlighted very importantly, mass gathering events, it's definitely a chance for outbreaks, and definitely we cannot predict which serogroup can be creating an outbreak in this sense. So these are the 2 available vaccines from GlaxoSmithKline. 4-component MAN-B, trade name is Bexsero. European Medicine Agency licensed in 2013 and FDA licensed in 2015. In the right-hand side, you can see in the column MAN-ACWY GSK vaccine, which is trademarked as Menveo. It's first licensed in Europe 2010 and simultaneously with US FDA at different age groups. And both vaccines are available and approved more than 45 countries. And if you're looking for the numbers, the actual number for Bexsero is even higher than 50, and for Menveo it's more than 66 million. And these are the currently available indication schedules. And I would like to give you a brief overview for ACWY vaccine because it started in 2010. And in 2020, there's one really important update, and I would like to add one slide for that. You can see we gathered first immunogenicity. That's the basics of the all meningitis vaccines. You can apply for licensure approval with the help of immunogenicity because this disease, although it's deadly, but thanks God, it's uncommon. So therefore, we can use immunogenicity in order to show increasing antibody results in the individuals who get the vaccine. That was the case for Menveo, but after spending 10 years, first in South Korea, we've been able to show a real-world data supporting ACWY vaccination. And this is the summary of ACWY vaccines, safety, immunogenicity, potential co-administration. And also, we know that there's in ACWY vaccination, it's a possibility of decreasing nasopharyngeal carriage is important, especially this has been shown into serogroup C, W, and Y. And this real world impact that I'm highlighting, it's definitely coming from South Korea, and it's coming from Korea Armed Forces, Republic of Korea Armed Forces, and they utilize 1.5 million subjects vaccinated with one dose of Menveo during the meningococcal vaccination program for 4 years. And at the end, they reduced the incidence rate by 88%. So this was very, very important because this was the very first real world data confirmed the same immunogenicity can translate a real world impact for adults and in this high risk group. And this is the currently available recommended immunization schedules. And if you would like to interested to learn more, we can our colleagues from GlaxoSmithKline Medical Affairs, they can provide more information. But basically, we can start as early as 9 to 12 months. This is specific to Saudi Arabia with 2 doses. And then in adolescency and adults, 1 dose required. And also for Umrah and Hajj pilgrims, 1 dose is required. And based on the Saudi Arabian Ministry of Health guidance, in every 5 years, if risk remains, there will be a booster recommended. So this is for ACWY. And interestingly, I would like to switch on for component MenB vaccine, which is Bexsero. It took more than developing the Menveo, that's for sure. And I would like to highlight on this because as in researchers and as a vaccine manufacturing company, we spent more than 20 years to develop MenB. And let me explain the reason behind this. Because we couldn't use the same approach of capsular vaccines, as you can see in here. We couldn't use why. It's very simple. Let me highlight in here. Because normally in ACWY vaccines, we can use polysaccharide capsule. It's very easy because for ACWY, polysaccharide capsule is enough immunogenic to create a robust antibody result. But number one, in MenB serogroup, it was not as immunogenic as the other serogroups. That's number one. And number two, and also this is, for me, this is more important than immunogenic because there is a structural homology between capsule B polysaccharide and the human neuronal tissue. So this might create, of course, an ethical consideration and a risk of possibility of creating autoantibodies. So for that reason, it took a while for us to understand what type of polysaccharide alternative we should carry on. One could be an outer membrane-based vaccines, because we know that there are some strains specific to serogroup B. They are creating outer membrane vesicles, and that protein could be useful. But unfortunately, this OMV-based vaccines is specific to that particular strain. And when you look for the historical background of the development of MenB vaccines, you can see in Cuba and in New Zealand, there are some specific attempts to develop MenB vaccines, but these were specific to those strains. So therefore, it took for us some time, especially for our researchers in Italy, they spend some time and they approach by highlighting an interesting approach by using reverse vaccinology, by identifying these proteins normally expressed through the surface of serogroup B. Why I'm calling it reverse vaccinology? Because in more than 20 years ago, two researchers, they put the entire genome sequence of Neisseria meningitis into a computer. Because normally as a classical vaccinology, we can work together with in vivo, with in vitro, with the pathogens and the possible antigens. After finding out these antigens, then we can try out to build up some vaccine candidates. But in this time, we can put the entire genome sequence into the computer in order to identify potential vaccine candidates. Then it's reduced to 350 surface exposed proteins, could be possibly an antigenic, and we identify 91 proteins, and then among this 91, 28 novel proteins defined as a bactericidal antibodies. So 3 recombinant protein candidates selected, thanks to computer work, and then it's combined with the New Zealand formulated outer membrane vesicle, and these are the 4 components put in the Bexsero, and it took more than 20 years. So in the idea behind this development, it was multiple antigens may provide synergistic killing and enable broad strain coverage. And in a nutshell, 4-component MAB vaccine development program, it's an extensive program. We conducted 17 studies, including 10 randomized control trials with more than 10,000 subjects. But for me, the most important thing is, and I would like to highlight real-world evidence, because these randomized control trials, what we have been able to show is the increasing immunogenicity and the antibody results. But with the help of this real-world evidence, it's definitely confirmed these good antibody results create an impact or vaccine effectiveness in the countries. For example, on the left-hand side, you can see England. Since they have implemented in 2015, September, and in their national immunization program, they reduced 75% the expected invasive meningococcal disease. In Italy, in 2 regions, Tuscany and Veneto, they use also in their infant national immunization program, and it creates 90% vaccine effectiveness. In Portugal, it tried in endemic setting, create 79% vaccine effectiveness. In Australia, 71% vaccine impact. And in Quebec, it's interestingly a different age group between 2 years to 20 years. Due to a specific region, MAB outbreaks, it has been carefully under control by reducing 96% of the disease incidence. So one thing is effectiveness and impact, but also as a doctors, we know that vaccines should be safe enough to provide protection for individuals, especially at the early age. So we try out in the multiple real-world evidence, and it confirms the safety profile of 4-component MAB, similar to what we have found in clinical trials. For example, in UK National Immunization Program, it shows no need safety signals, and no increase in seizures, no Kawasaki disease or nephrotic syndrome. And also the other countries' outbreak setting usage, like in US or France, it confirms that in line with the current label of Bexsero. So if I can summarize, current recommendations as of July 2022, Bexsero has been introduced into 12 national immunization programs or regional immunization programs. There are 34 clinical recommendations, and more than 45 countries approved Bexsero in their usage, including Saudi Arabia. And also, I would like to highlight in here, thanks to Saudi Society of Family and Community Medicine, Saudi Epidemiology Society, and also Saudi Society for Medical Microbiology and Infectious Disease, they have been identified the importance of broad coverage especially when we are facing an Hajj and Umrah after COVID era. So therefore, they have recommended a broader protection for invasive meningococcal disease and considering meningococcal vaccination against AACWY as well as MenB. So these are the countries currently recommended. As you can see, there are different modalities. In UK, they are using 2+1. In South Australia as well. In Italy, they are preferring 3+1 like San Marino, but most of them, they are preferring 2+1 for their infants and early vaccinations. And this is the current posology as an approved Bexsero label in Saudi Arabia. This is the only MenB vaccine available in Saudi Arabia, available for infants. If you can use as early as possible, you can use either 2+1 or 3+1 doses. And after the age of 2, you need 2 doses. +1 and the booster dose should be considered only in individuals at continued risk of exposure. And this booster timing hasn't been established yet. But one of the questions that I'm receiving very frequently, I would like to answer it here. We have a long-term follow-up study among adolescents. It confirms 7.5 years. And earlier ages, it's 4 years. So we have enough data to confirm for adolescents, 7.5 years, it shows the persistence of antibodies. So for me as a healthcare professional, this is the most important thing that I would like to highlight. Even though we are talking about vaccines, but vaccines itself cannot save lives. Vaccination does. So for that reason, I would like to thank you all for your attention. And I will be very happy to answer questions or listen to your comments. Thank you very much, and shukran.
Thank you so much, Dr. Sardar. That was a very solid statement. Vaccine will never curb the epidemic, but vaccination will do. Thank you for this, and thank you for the wonderful presentation as well. So, ladies and gentlemen, I would like to invite all the speakers now for the panel of Q&As. And in fact, we have a good interaction with the audience. We received many questions, and I would like just to highlight, to forward the first question to Dr. Sarah. Dr. Sarah, there's a question for you as a family physician, sitting as a gatekeeper in the healthcare system and saving, and safeguarding, the community health. What is your strategy to enhance the vaccine acceptance and to counteract the vaccine hesitancy from your own clinical practice? Thank you.
Well, honestly, it's just more education, health promotion. I think the public in general have lost trust because of social media mainly. It helps a lot to take time with your patient to explain, not to make them feel rushed that they need to take it. I have a patient who came to my clinic 5 times before he decided to get the influenza vaccine. Every time we're pushing for it, even if he comes for a medication refill, persistence, and at some point they usually will go for it.
Okay, perfect. And I think also we have to consider that there is factors that is contributed for the people and for the patients. And another thing is our clinical inertia. We are reluctant to highlight the issues of vaccinations across the board, regardless of the specialties. So this is the responsibility of everyone, regardless what specialty we are working through. So thank you so much. A question for Dr. Salah. There is a question came from one of the audience. His name is Dr. Majid. He's asking about the prophylactic antibiotics, which has been used for meningitis for many, many years, like ciprofloxacin or even rifampicin. What was the impact of these for enhancing the resistance of the new serogroups?
Oh, well, the chemoprophylaxis has, in general, played a fundamental role in reducing the spreading of the disease, particularly among the contacts. There's no doubt for that. And there's a lot of literatures, tons of these literatures that's supporting that. And this is why the Saudis, they have adopted the prophylaxis upon arrival for some of the countries to reduce the courage rate among the certain group of people, which is, I believe, this is absolutely right to do that, and if it is used rightly by default, is going to yield a very excellent protection among the contact. There's no doubt for that, and this is something that has been widely recommended by many organizations, including the World Health Organization and others. So there's no doubt for that. Well, whether the usage of the antibiotic could cause any resistance, I don't remember anything in that direction, unless maybe Dr. Sarah has to comment, or Dr. Sardar. I don't remember anything that has been published in that direction. So I won't be able to respond to that question. Maybe the colleague will be able to do that. Thank you.
Okay.
Up to my knowledge, there is no certain resistance in Saudi Arabia to ciprofloxacin. However, I remember at one time we have an ID doctor who actually said they always prefer to use ceftriaxone because of the IV intramuscular route would decrease the resistance for the compliance, even as a prophylaxis. It is listed also in UpToDate as one of the approved prophylaxis, ceftriaxone.
And it works also on the nasopharyngeal carriers as well. So this is another spectrum of the benefits of using the prophylaxis. Dr. Sardar, there is a question for you. The vaccine impact of MenB, we know that it has been implemented successfully in many countries like UK, Ireland, Australia, and Canada. So what was the impact in terms of reducing the incidence of MenB in those countries?
Well, I can give you a great example in UK, because they have started to use as early as 2015, 2+1, and they impacted by 75%. So if they haven't used MenB vaccination with 2+1 in the infancy, they have seen more cases, and the numbers are, if you allow me, I would like to represent the numbers, because these are really striking numbers by 75. And if you can give me a moment, that I would like to represent. Yes. And so they averted one case in every 4 days. That's their finding, and it's not a GSK publication. And this disease reduction by 75%, and the confidence interval, it was really between 64 to 81%. So for us, it definitely represents some proper significant impact in the England. And also the Italy, they have, however, they are using 3+1 schedule in Tuscany and Veneto when you're looking for the vaccine effectiveness, because the impact in England, it's the comparison of incidence levels before the implementation of the vaccines and after the implementation of the vaccines at the end of the 3 years. But however, in Italy, they compare the vaccinated population versus unvaccinated population, which gives us vaccine effectiveness. This is also important finding. In Tuscany, they find out 93.6% vaccine effectiveness. In Veneto, this was 91%. And one thing that I would like to highlight, although this represents great real-world evidence, but the most important thing is adherence or coverage rate. Because if you can have a vaccine in your national immunization program, but if your vaccination coverage rates, it's dropped less than 70 or 80%, this would definitely wasting your money. As a public health specialist, for me, whichever vaccine that we are going to use in national immunization program, and Saudi is a great example for that by achieving more than 95% vaccine coverage rates. I think this should be the case for any vaccine in the national immunization program. And thank you for asking this question.
I think this is very encouraging, results and impact that make the other countries more, more proactive to adopt this kind of recommendations. But the big question is why we are so late to implement this. In the Kingdom of Saudi Arabia, although we know this is the kingdom hosts, this kind of global mass gathering and the risk. But I think we are on the right track. Still, we have now we're having more evidence than before, and I think this will make the decision makers to take the step very shortly, inshallah. Dr. Sarah, there is a question: are the current vaccinations requirements in Saudi Arabia considered enough for protection?
Yes, unfortunately, currently, regarding meningitis, it is not enough because, like we said, meningitis serotype B is emerging. So if you go to Hajj and you're going to come to my clinic and receive the quadrivalent, which is available throughout Saudi, you're not going to be protected against serogroup B, and this is still a risk. So you need to tell your patient that he's not protected against certain type. Same thing for the will baby immunization. We give the conjugated meningococcal vaccine at 9 months. It's also the quadrivalent serogroup B is also not included.
Okay. Thank you so much. Dr. Salah, from your own experience and being in the position that you are oversighting all the actions that is taking, to implement the eradications of meningitis, are we ready to have the eradication of meningitis by 2030 with all the evidence that we have and all the tools we have and all the achievement that we have reached for? Do you think that we will be able to?
Well, this is thank you so much for the question, and this is a very tough question, in fact. And because if you look at the ingredients of elimination, and we need to look at those 5 pillars that I've spoke about it, and look at each of these pillars, whether these pillars are very adequately been implemented in our countries, whether in Saudi Arabia or in other countries, and you will be able to tell whether in the right direction or not. And in particular in Saudi Arabia, I could say, in general, the country is very much in the right direction, honestly, in the right direction. But again, there are a lot of minor tunes that need to be done now. And one of them is prevention, introduction of more prevention. This is one that we have the vaccine that we could introduce. Surveillance system need to be further tuned, I don't think, personally, I was in Saudi Arabia last week, and we had a similar discussion. And while I was discussing with a lot of physicians in front of me, people like you, and many of them, they will say, yes, we have seen the disease recently. So where are they? They don't reflect in the surveillance system. It means the surveillance system need to be really good enough. So we need to tune the surveillance system. And another thing, when you talk about surveillance, there is active surveillance and passive surveillance and diagnostic as well, because the current diagnostic maybe is not enough. You need to adopt something like more advanced diagnostic tools in order to identify, because the current one is not adequate enough. And the studies has been shown that the usual one, which is blood culture, could yield the good, but multiplex tests, that's really could you be able to pick up to 70% of the cases, whether they are on antibiotic or not. So the diagnostic tool need to change. So this is the third one. The other thing is a long-term follow-up of the individuals who being affected with the disease, which is hardly you could find any surveillance in the place, because these patients, they may not show any sort of problems in 1 month, 2 months, but as time goes by, definitely there will be some problem, and we know that. So the surveillance need to be in place in order to support this. So when somebody coming to evaluate, they're going to evaluate all these 5 pillars. So unless these 5 pillars are very well articulated by the national level, we won't be able to say yes, that particular country is certified to be eliminated, meningitis elimination. I'll stop over here.
Okay, thank you, Dr. Salah. You said it very elegantly. I enjoyed the way you have stratified, the solutions and how you look into I think it's an eagle eye, looking into the problem sharply and identifying where are the pitfalls. So thank you very much for this kind of elaborations. Dr. Sardar, what is the importance of the real world data? I think we have answered this question partially, but this question has been repeatedly asked. So if you would like to elaborate on this, please.
Well, thank you very much for asking this question, sir. I think it's particularly important if you know the historical background of the licensure of meningitis vaccines in general, because whether we are talking about pneumococcus or talking about Neisseria meningitis vaccines, in the licensure, you have to apply with the immunogenicity results, which means you can give vaccines in healthy individuals, then you can collect the blood samples and to confirm expected increase of antibodies. But in the real world data, this in parallel, it confirms this increased antibodies. It creates a link with the protection, because real world data, it takes some time because we are lucky enough for having this data and being able to represent, because these are the uncommon disease. And if you would like to represent the impact of this disease, it takes an additional years. For us, it takes more than 3 years to be able to share the results of UK. And for Memveo, it takes more than 10 years to be able to show some real world data show the 88% impact. So it takes some time, but we are lucky enough, because if you are asking me this question 5 years back, I can only represent you the immunogenicity results. And you can ask me and challenge me very easily, Dr. Sardar, is this data confirmed the real world? We should say possibly. But right now, very confidently, I can confirm that these are the results retrieving from the independent researchers in the countries located in the all over the world. Thank you.
Oh, thank you, Dr. Sardar. The last round of questions now, Dr. Sarah. There is a question from the audience that say, do you think that the preventive measures that has been taken during the COVID-19 impacted positively in reducing the meningitis incidence during globally, even nationally? Do you think that this is correct?
I think it definitely did. Anything that is transmitted basically by close contact and by touching and by being in a big place or gatherings, it did decrease during COVID. So I think the incidence of meningococcal disease has also been less. However, I think an ID doctor would be more suitable to answer the exact incidence rate. But from our point of view, we honestly see less infectious disease in the last 2 years.
Yeah, in general, all infections has been,
yes.
Yeah,
Definitely.
even influenza as well, So now we're getting the real season, yeah. All right, thank you so much. I think there is a strategic question for you, Dr. Salah, as long as you are in that particular position, looking into the things globally. How can Saudi Arabia utilize the roadmap and the global initiative to fight the meningitis to create a new strategy needed to fight against the disease? This is very highly strategic question. Thank you.
Yeah. Thank you so much, Dr. Ashraf. This is quite a great question. We know that countries sometimes they are struggling in introducing any sort of prevention, whether this is vaccine, that or this. And I believe these sort of global strategies need to be utilized efficiently in providing, because sometimes, just to put it in a different way, because I'm in the Ministry of Health, and I understand very well how difficult sometimes to convince decision makers sometimes with all these problems in their head in one of the element of introduction vaccine. But when you tell them, for example, this is an initiative that you have signed, because our minister has agreed, all of our ministers have agreed to this initiative. Therefore, we need to do blah, 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 blah in order to reach the target. I think it will be much easier and much smoother in taking up the recommendation. So I believe this initiative is a tool, and the people in the Ministry of Health have utilized it efficiently. I know there may be a problem of sufficient data to justify it. This is another problem, which is the decision maker, they need the data. Unless you have the data, you cannot justify it. But other way around, by default, we know that the global initiative is one of the fundamental way to put up problem and to say, because you have signed this one and we would like to adopt 1, 2, 3, 4, 5, 6 strategies in order to reach the target within 7 years, it will be much easier to be taken. So I believe Saudi Arabia will be among the first few countries will adopt that. I totally agree with that. I'll stop over here.
Okay, thank you so much, Dr. Salah. I think we came to the end because most of the questions has been answered and repeated. So with this, I would like just to close the sessions by just summarizing out of all what has been said by our elegant speaker. I would like to tell you, ladies and gentlemen, that Hajj and Umrah mass gathering is a very unique gathering that we have been engaged in the Kingdom of Saudi Arabia by hosting this gathering, and it's create a kind of local and international outbreaks of the disease. So this is one of the anticipation that we are anticipating by this kind of gathering. And as it said clearly by our colleagues, invasive meningococcal disease can progress from non-specific symptoms to death within 24 hours. You said it clearly, Dr. Salah. And the current meningococcal vaccine not protecting against all serotypes or serogroups, Hajj and Umrah event are still susceptible to outbreaks of the disease, including those due to serogroups, which is not included and required vaccines such as the serogroup B and X. You said it, Dr. Sarah. MenB reported to cause disease in Saudi Arabia, and the third most frequent serotype in the region. And the MenB is globally preventable and increasing. Furthermore, MenB becomes the most predominant serogroup in the Middle East and the Arab countries. So this will highlight the importance of thinking about MenB to be included in order to have the complete coverage of and protections for our pilgrims locally and internationally, even the contacts after Hajj. This is another way to go. So with this, ladies and gentlemen, I would like to, on your behalf, to thank all our guest speaker, Dr. Sarah Al-Muammar, Dr. Salah Al-Waidi, Dr. Sardar Ostrak, for their wonderful contribution for the success of tonight's scientific event. I would like to thank JSK Company for sponsoring this event, which was organized professionally by the Fexus Company. And I'm sure that you have enjoyed all the quality of information that we have gained today. And I hope that we will carry this kind of evidence-based proved information along with us as an ambassador to disseminate it across the contacts of us in hospitals, in polyclinics, and everywhere, wherever we come encounter to serve our patients. So with this, ladies and gentlemen, I would like to thank you for your attendance. MashaAllah, we have reached 1,500 attendees, and it's quite impressive. And even the quality of questions was quite amazing. And with this, I would like to thank you all, and stay tuned with us. Every 2 weeks to 1 month, we have another session to get all of you together along with us. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you.
يعطيكم العافية. شكرا جزيلا. Thank you so much for you, all of you, Dr. Sarah, Dr. Saleh, Dr. Sardar. And I would like to thank the people behind the scene, Dr. Khoja, Dr. Mr. Hassan, and all the supporting team from Fexus Company, Dr. Mansour Khalaf, and Dr. Khalid as well. Thank you for being with us.
شكرا.
طيب يلا في أمان. السلام عليكم. From Fexus Company, Dr. Mansour Khalaf.
شكرا لكم جميعا. دكتور أشرف، الزملاء الكرام، شكرا.
يعطيك العافية دكتور عبد الشكير، شكرا جزيلا لك.